the
All right, let's reconvene. So I will post some additional GT PAL practice questions for you up on Moodle, okay? The other thing is I owe you some practice questions just in general. I did not get them on ExamSoft in time, so I'm going to post a Microsoft Word document that has review questions and it has the answers and rationale. So stuff on this rainy, dreary weekend as you're studying, okay, you can kind of take a peek at those things. All right. So physical assessment. With physical assessment, one of the key things that helps us know the baby's growing is fundal height. We usually don't start fundal height measurements until around 20 weeks or so because the fundus has to get enlarged to be able to actually feel the fundus. Remember, initially you're not going to feel the fundus, but as the baby starts to grow and get bigger, it starts to enlarge. So usually around 20 weeks or so, we'll start measuring the fundus, and it's best if you can kind of have the patient with the head of the bed down slightly, and you're measuring from the top of the symphysis pubis to the fundus. So what's the need to know? The need to know is that the fundal height should be plus or minus 2 centimeters of gestational age. That tells you that it's within normal range. So for example, if the patient is 24 weeks, it would either be anywhere from 22 to 26 would be okay. So let's say the patient is 24 weeks, but the patient is measuring 30 centimeters. So the fundus is larger than what we would expect. It may be that there's too much amniotic fluid. It may be that the baby's larger than what we would expect. There may be more than one baby in there. Now, if the fundal height is smaller than what we would expect, that might be a data point for us as a nurse that would cue us in about poor nutrition, drug use. There may be poor perfusion to the baby. Okay? So fundal height is usually measured at every prenatal visit after about 20 weeks. 20 weeks is in the second trimester. Yes?
You said plus or minus
2
2 of the gestational week of what they should be?
Yes, yes. Now with the baby, once you have fetal movement, you're gonna say positive fetal movement. Quickening is different than kick counts. Quickening is a fluttery movement. So when moms first have quickening, they're not quite sure. It's like, it's a little twinge, there's a little movement. It's like, was that gas? I don't really know. So it's not real demonstrative. It's not like, boom, ka-chow. That's definitely fetal movement. But you'll notice it happening more frequently, and the movement gets more discernible. So I will say, when we talk about kick counts come into play a little bit later, usually around 28 weeks or so. So quickening is the first fetal movement, but I'm not counting the movements until around 28 weeks, which is the beginning of third trimester. I shouldn't anticipate the baby's moving, but I don't perceive fetal movement in the first trimester. So the patient comes to you, she says, I'm 14 weeks pregnant, should I be feeling the baby move? I'm worried. Your response would be, no, it's too early. The baby's moving, you just can't feel it yet, okay? Fetal heart tones, same as fetal heart rate, so you can get them by Doppler or ultrasound, which is the same technology. If a mom gets a very, very early ultrasound, sometimes in the fetal development, we can't see all 4 chambers of the heart. So in other words, we just kind of see a little flutter there. Baby almost looks like a grain of rice. It's really, really hard to see things. And so what they may do is a very early ultrasound to say, yes, there's a pregnancy, it's in the uterus, I see heart tones, but then they'll do a later ultrasound to do an anatomical survey, because not all the anatomy is quite there yet at 8 weeks gestation. Ultrasound, non-invasive, easy, gives us a good indicator about fetal well-being. All right, need to know this. This is not explained very well in the book, and it is importante, okay? You need to know this. So the initial lab work, this is part of the prenatal panel. We don't go off what the patient says her blood type is. So we draw blood, and we look not only at the type, but the Rh factor. So the type is the letter, the factor is positive or negative, all right? Most women are Rh positive. Some women are Rh negative. If you're Rh negative, then that would mean you are a candidate for RhoGAM. If the father of the baby is also Rh negative, you would not need RhoGAM. Okay? CBC, you should be familiar with that. You've seen CBCs on tons of patients. We just want a baseline to see where she is in terms of her white blood cell count, her hemoglobin, and hematocrit. Okay? So again, all of that should be pretty normal. Antibody screen, okay? That antibody screen is either positive or negative. Normal result is negative. The antibody screen detects whether there is any abnormal antibodies in maternal blood. The other name for this test is indirect Coombs, okay? Now, my really smart, savvy, on top of it folks are like, wait, why are you getting an antibody screen on an Rh positive mom? I get it. It's part of that prenatal panel, and so we often have that reported. There can be other antibodies in there, but if the antibody screen is positive, it usually means that there has been some formation of antibodies in maternal blood from an Rh negative mom having an Rh positive baby. We see that in women who did not have access to RhoGAM from a miscarriage or other pregnancies. So let's say a patient delivered in a different country or had a pregnancy in a different country, had a miscarriage and never got RhoGAM. So she may have a positive antibody screen. 90-ish% of our patients are gonna have negative antibody screen. So that's normal and expected. And the other name for it is indirect Coombs. Now, my nursing care for taking care of a patient with a positive antibody screen is really not any different. The big thing is she's not gonna get RhoGAM because RhoGAM's not gonna do anything. RhoGAM prevents the formation of antibodies and you already have the antibodies. But she still has routine prenatal visits. There's some risk to the baby, but we'll get to that when we get to pregnancy at risk next week. Varicella and rubella titers, we want to see varicella immune and rubella immune. This is important. We do not immunize against chickenpox and rubella in pregnancy. So we noted that she's non-immune, and then we're gonna immunize her postpartum. So we noted, but again, in terms of abnormal data, I don't get like, woo, she's rubella non-immune. I would be much more, woo, if her hemoglobin is none, okay? HIV. So with HIV, the recommendation is that we HIV test all pregnant women. Have you heard about opt-in and opt-out? Has someone talked about that at all? So opt-in means that you would sign a piece of paper and say, yes, I want the test. Okay, that's opt-in. Well, a lot of people are like, I don't have HIV. That's for IV drug users and gay people, and that's not me, and whatever. And so we would rather people opt out. So the idea with opt out is that we test everybody for HIV, and if you don't want, you have to do an extra step to say, nope, I don't want that HIV test. And the reason why we make such a big deal about HIV in pregnancy is because we can treat you very effectively in pregnancy and prevent transmission to the fetus. So like we used to do C-sections on moms that were HIV positive. We don't do that anymore because we're much better at treating HIV in pregnancy. Okay. HIV positive or negative, so it's good to know HIV status because of the potential for transmission to the fetus. All right, I think you had this on your worksheet. Hang tight for just one sec. hepatitis B surface antigen. You might see this abbreviated like so, HBsAg. Is that something on your worksheet like that? Okay. So hepatitis B surface antigen does not test for the presence of hepatitis, it tests for the exposure to hepatitis. So it doesn't say you have active disease. All it's saying is you were exposed to it at some point. If you have a positive hep B surface antigen, it means that there was exposure at some point and that we have to do extra precautions with the baby after delivery. So we want to give hep B vaccine to the baby, but we're also going to give some immunoglobulin to the baby after delivery. So the important thing, this is where students get mixed up, they think that that tests immunity to hepatitis B. Because remember, you guys had your hep B vaccine and you might have had to get a titer and you were immune. This is a different lab test. You had a question, Morgan? So opt-in means that I have to say, Dr. Jones, could you do an HIV test on me? So I would have to ask for it to get the test. And so there's a movement that HIV in pregnancy should be an opt-out. So we do it routinely on everyone. And so you would have to opt out saying, oh, please don't do that HIV. I specifically don't need you to do that HIV test on me. So we're capturing more people to see if HIV is there. And it's because it's not that we're trying to share personal information with insurance and things like that, but it's because we have such treatments that are excellent in pregnancy to prevent transmission to the baby. But some people have some, ethical issues with being tested for HIV. All right, STS, and the old name is BDRL, and I don't remember what was on y'all's worksheet. Okay. RPR, yeah, okay. So this is a test that has a lot of different names. And so what's the need to know? It's screening for syphilis. Syphilis is on the rise. We've had more cases of syphilis in newborns recently, nationwide. And so we want that test to be non-reactive. Non-reactive. If it is reactive, we're gonna do some further testing, but usually what will happen is they will treat the patient for syphilis and they have to treat her partner for syphilis as well. Otherwise she'll just catch it again. Syphilis can cause you to miscarry. Rubella can cause you to miscarry. Varicella can cause you to miscarry. You can also have some genetic diseases from exposure to pathogens, particularly in the first trimester. Pap smear. Pap smear, we're trying to get those cervical cells. We are screening for what? HPV and cervical cancer. Sometimes in pregnancy, it's really hard to get those into cervical cells, and the reason why is because in pregnancy, we have increased mucus secretion, so when they go swab the cervix, they don't swab enough and get those tiny cells to put on the slide to be able to look for that. Now, if I have an abnormal pap smear when I'm pregnant, they usually don't do too much about it. They usually just watch, wait and see, and they'll address it after pregnancy. Because most of the time, it's not anything that I have to do a major intervention for. If it is something I have to do a major intervention for, that means, again, there's something wrong with the cervix. You're gonna have to do a cervical biopsy or something like that. Put you at risk for shortened cervical length, would put you at risk for preterm delivery. So we would really rather wait and do that after delivery. Gonorrhea and chlamydia cultures. So those are vaginal swabs. And again, you can be cured of syphilis, gonorrhea, and chlamydia, all right? Healthy people a lot of times clear HPV on their own. Some women do not. Some women are carriers of HPV, and then some women, HPV turns into cervical cancer, okay? And then a urinalysis, and then a culture and sensitivity, particularly if the patient tells us in the history she's had recurrent UTI, kidney infection, pyelonephritis. It's very common to have a UTI in pregnancy, so if we know that this patient's prone to them, she's even more at risk, so we want to kind of be proactive there. Remember, UA just tells you the stuff in the urine, the culture and sensitivity. The culture part tells you what it is, the sensitivity tells you what antibiotic the patient needs to be on. And your antibiotic needs to have an S next to it for Superman. You do not want the antibiotic with R next to it for resistant. All right, so the initial prenatal visit. I got my bag of goodies, I got my prenatal vitamin, I was at the doctor's office for 3 hours. Whew, ready to go home and take a nap. That is a pretty normal experience for a woman. So if you have somebody who's working and they can only ask off, I would probably ask off for maybe half a day, 4 hours of work, okay? Maybe they're a while. Some of our OB offices, a patient will go for a 2 o'clock appointment, and it just so happens that all of the providers are doing deliveries. So guess what? You're gonna have to come back on a different day. What? We'll get what we can today, but you'll have to come back for other things. Some of our OB offices are super busy, super busy. And so what they have done is they've added nurse practitioners to be able to do prenatal visits because the docs are doing surgeries and deliveries. So that's one of the questions your patient might ask is, am I gonna see the same provider every visit, which is ideal, but in some cases they want you to see different providers, so whoever's on call for delivery kind of knows you, okay? So your subsequent prenatal visits, these are things that would be done at subsequent prenatal visits. So looking at this list, do you see anything invasive? Not at all. Could a nurse do all of those things? 100% absolutely, okay? So the idea of I have to see the doctor is actually, not so sure. Now, some things outside parameters, yes. But a lot of this can be done by a registered nurse. And in some parts of the country, it's done by a registered nurse. Registered nurses go to patients. So the patient with no transportation isn't getting on a bus with her 2 kids and sitting in the doctor's office for 3 hours waiting for a visit that lasts 7 minutes. She can stay at home with her kids. The nurse comes to her house, brings a Doppler, brings a scale, brings urine dipsticks, does it all in the comfort of the patient's home. And if that helps the patient get adequate prenatal care, gets early detection of any problems. Now certainly if there's a problem, we're not gonna have her stay home. We're gonna have her come in and see the healthcare provider. But these are all very basic things. Now, this is why patients don't come to prenatal visits, because their perception is, well, you're really not, I know if I'm feeling good or not. I can tell, this is my 3rd baby. Why do I need to come and have my blood pressure taken? Well, because you're 40 now, you're 40 pounds overweight, and you're at higher risk of having preeclampsia because of your age. So we need to monitor it. You can't just look at you and say, oh, your blood pressure's below 120/80. So there's an assessment guide in the book that kind of reviews that, and I want you to write down, this is again the routine pattern for prenatal visits. All right, so you know this as change. In OB, it means trimester. Okay, so first trimester. You are coming to the physician's office, midwife's office once a month. Okay, so if I see you on October 31st, you're in the first trimester, you're 8 weeks. I'm gonna see you in 4 weeks, which is still 12 weeks. I'm still at the tail end of first trimester. Second trimester, still every month. Okay, and it's because, again, that's not a big risky time in pregnancy. Again, if you're having some bleeding, you're having some nausea and vomiting, we might see you more frequently, but for healthy pregnancy, still every month. The change happens on 3rd trimester, which is around 28 to 30 weeks. We change to every 2 weeks. Every 2 weeks. So this is important because we have a change in what we do with labs here. We repeat some of our lab work here, and this is also where we would give RhoGAM, and we would do gestational diabetes screening. We're not done yet. So now I'm coming every 2 weeks. So my patient who was seen at 28 weeks, had her screening for gestational diabetes, we're gonna see her in 2 weeks. When we get to 36 weeks, which is hard to see down here, so we'll move it up here. 36 weeks, we change to once a week until delivery. Okay? So the beginning of pregnancy, we see you once a month. Around 28 to 30 weeks, the beginning of third trimester, you increase the frequency, come every 2 weeks. At the end of pregnancy, you come once a week. So you can see that during pregnancy, you may need to take some time off from work to come to prenatal visits. All right, in the second trimester, somewhere between weeks 16 and 19, we're gonna get an ultrasound. Not all women get ultrasounds at the very beginning of pregnancy. Here in Louisville, we do a lot of ultrasounds. A lot of our OB offices actually have ultrasound technologists in their office. They can bill you for it. So during this time of 16 to 19 weeks, which is second trimester, we can do some lab work, which is the quadruple screen. And with the quadruple screen, it is optional, so a patient can opt out of that. So the quad screen, we're looking for 4 biochemical markers. One of those is the maternal serum alpha-fetoprotein test. The quad screen simply tells you, based off those biochemical markers, are you at increased risk? It is a screening test. It is not diagnostic. So it would tell you that based on your age, your gestational age, and the biochemical markers, what's the risk of having a baby with a chromosomal defect? What's the risk of having a baby with a neural tube defect? So let me give you an example. A normal healthy mom might have, based on her age and gestational age, a risk of 1 in 2,500 of having a baby with Down syndrome. She has this test performed. The test indicates that the risk is 1 in 99. That would be considered a positive quad screen because the risk is greater than it would have been on age alone. But still the risk is 1 in 99, so it doesn't mean that she's definitely having a baby with some type of health issue. So when I have a positive quadruple screen, I usually go to an invasive test, and usually it's amniocentesis to be confirmatory. Now, the patient says, I don't want to have an amniocentesis. Can she do that? Patients have the right to refuse because what's the risk with amniocentesis? Bleeding, infection, ruptured membranes, I could lose the baby. And if I'm not gonna do anything about the results, why would I have that? But some women want the amniocentesis, they want confirmatory, I want to know now so I can make plans, so I know. Okay? With amniocentesis, it is rare. It's only for high-risk pregnancies at this point, and the only reason we're doing it is for genetic conditions. If mom is Rh negative, she'll need RhoGAM. So on Moodle, I have made you a cheat sheet. Right here, this RhoGAM info sheet. It's a good little nugget of information because again, I feel like the information about RhoGAM is a little bit sliced up in the book. RhoGAM will be on, I guarantee you RhoGAM will be on every single exam. So you have got to know RhoGAM forwards and backwards because as a nurse, you could be a PACU nurse, you could be an ER nurse, you might be a peds nurse, and I mean, so we see RhoGAM everywhere. RhoGAM is never given to babies. RhoGAM is only given to Rh negative moms. So this kind of guides you through RhoGAM. And I've given you some links here, so if you want to know more about RhoGAM and specifics that you have that. Okay. Now, we see her at 16 weeks. She gets an ultrasound and a quad screen. When does she need to come to the office again? She was 16 weeks. 20 weeks. At 20 weeks, when does she come again? 24. At 24, when does she come again? 28. Okay? And then it changes. At 20 weeks, we're gonna ask her about fetal movement. First time moms sometimes don't perceive fetal movement until a little bit later. Second time, third time moms perceive it earlier because they know what they're feeling better. So somebody who's a gravid 1, para 0, if she says, I'm not feeling the baby move at 20 weeks, do I need to be concerned? Not necessarily, as long as the fundal height is appropriate, plus or minus 2 of 20 cms. Everything else looks okay, but at 24 weeks, she definitely should be feeling the baby move at 24 weeks. Okay. Third trimester at 28 weeks, we do a 1-hour glucose tolerance test. So on your worksheet, you have on there about a 1-hour glucose tolerance test. It is a screening test for gestational diabetes. It is not diagnostic. I believe you have a spot on your worksheet for 3-hour glucose tolerance test. You need to have 4 values for the 3-hour glucose tolerance test. 3-hour glucose tolerance test is diagnostic for gestational diabetes. You have fasting, you drink a real sugary drink, and then we draw your blood 1 hour, 2 hours, and 3 hours. Okay? There's a nice little chart in the pregnancy at risk chapter that gives you the values for each one of those glucose tolerance tests. Most women get the 1-hour glucose tolerance test, and the key value is less than 140. Less than 140. Okay? Now, at 28 weeks, we might repeat the H&H, and we may also repeat the antibody screen. This is super important. Okay? So here in the United States, we routinely give Rogaine to Rh-negative moms, even if dad is Rh-negative, even if dad is Rh-negative. Now, some people will have blood tests on mom and dad. Some people have religious reasons for not wanting Rogaine. A Jehovah's Witness may refuse Rogaine because they perceive it as a blood product. Okay? If both parents are Rh-negative, then we don't have any issues with the antibodies. But I think, again, if she's Rh-negative and Rogaine prevents the formation of antibodies for about 12 weeks, so if you get it at 28 weeks, that's going to cover you to about 40 weeks, and you should be fine. The biggest risk of forming antibodies is at the time of delivery. And remember, the Rogaine, particularly in the first pregnancy, is not protecting the current baby. It's actually preventing antibodies down the road and future pregnancies, okay? Now, after delivery, we know the baby's blood type based off cord blood. If mom's Rh-negative, the baby's Rh-negative, there's no need to give postpartum Rogaine. So why do we do it during pregnancy? Well, we don't want to do anything invasive to find the baby's blood type. It would put the baby at risk. And the risk of giving you Rogaine in pregnancy is very, very low. There's very little complications or anything associated with it. So better, more pros than cons. Okay. Now, if patient is high risk, we're going to do ultrasounds, non-stress test, and biophysical profiles. That is all assessment of fetal well-being, which is Thursday's lecture. Okay. So here are some examples of these. Do you guys know what IUGR is? IUGR? Intrauterine, it's growth restriction. The old term used to be retardation, and we don't use that term anymore. So it's intrauterine growth restriction. And then oligo, too little fluid. Polyhydramnios, too much fluid. All right, so here's your danger signs in pregnancy. So any gush or leaking of fluid from the vagina is abnormal. That would be concerned about premature rupture membranes. Any vaginal bleeding, abdominal pain, a fever. So pregnant women, if they run a fever, we don't consider that to be normal. So you might tolerate a fever and you kind of take some Tylenol and you feel better in a day or two. In pregnancy, if you run a fever, you need to be sure and let your healthcare provider know, because we're going to watch you more carefully, because infection could put you more at risk. So like the flu can make pregnant women so sick they have to be hospitalized. They actually end up in the ICU, and they visit you at the ICU nurse, okay? So as the ICU nurse, I need to know that as I'm taking care of my patient on the ventilator who has the flu, who is pregnant, that I need to do Doppler tones to hear the baby's heartbeat, okay? Dizziness, seeing spots before my eyes, that can be a sign of hypertension, preeclampsia. Headache, edema. So this list does not prioritize, but when I look at this list, I see some things, and certain things are like, and other things I'm kind of like, edema of the hands and face, I'm kind of like, I'm concerned about that. Seizures, I'm more, that's pretty serious. So if a patient has a seizure, she needs to immediately go to the hospital. We don't have her stay at home. Seizures are what kill babies and kill moms, and they happen a lot to preeclampsia. So I don't know if anybody watched Downton Abbey, the lady died and she had preeclampsia. So we'll talk a lot about preeclampsia. You'll see it on this list quite a bit. Dysuria, urinary tract infection. And then absent or decreased fetal movement. And we'll talk about when mom perceives decreased fetal movement, some things she can do to help better assess the baby's well-being. Again, super important, signs of preterm labor. We provide this education to the patient after about 20 weeks. Any bleeding or cramping in pregnancy is not normal. The problem is that if you have bleeding or cramping in first trimester, a lot of our interventions will not work. So I can't put you on mag sulfate. Even putting you on bed rest, if you're gonna lose the pregnancy, unfortunately, you often lose the pregnancy and you lose the baby. So it's really sad. Later in pregnancy, we sometimes have some interventions that can stop labor. I think a lot of women think pain is normal as in pregnancy, but the pain with preterm labor is different than kind of musculoskeletal pain. So it feels like you're starting your period, it's low, it's dull, it's achy, it's intermittent, there may be a change in your vaginal discharge. And again, sometimes you have some diarrhea with it, and again, that has to do with some of the prostaglandins that get released when you go into labor. So these would be, again, if your patient has any of these symptoms, they need to be seen immediately. And with OB, I'll be honest with you, better safe than sorry. So it's better to come in, get things ruled out, and send you home. In the third trimester, the last month, we're changing the frequency of our visits, so right around 36 weeks. Again, there's something unique about 36 weeks. At 36 weeks, you're going to get the group B strep culture. That's important. Group B strep. Now with group B strep, and again, I know it's late and I know it's Friday, but this is a critical data point. We do not treat mom at that time. We treat mom in labor. So group B strep often does not make mom sick, but oh my goodness, does it make babies sick. So if you're GBS positive at 36 weeks, we note that in the prenatal record, and then when you're in labor, you're going to get antibiotics in labor because transmission occurs as the baby comes through the vagina. Now, if you're gonna be a C-section, a little bit different. But GBS is not like strep throat. It's not like, oh, we found out you have it, here's 7 to 10 days of antibiotics and it'll go away. Again, the big concern is transmission to the baby with vaginal delivery. So if your water breaks, that's even more exposure. So with those patients who are GBS positive, group B strep positive, it's really important that when they have signs of labor or if their water breaks, they need to be seen in the hospital and get antibiotics because we really want to try and get at least 2 doses of antibiotics in prior to delivery. But we treat mom with antibiotics in labor, not at 36 weeks, not in the doctor's office. You might repeat the gonorrhea and chlamydia cultures. So sometimes with sexually transmitted infections, you might see where it notes TOC. TOC is a test of cure or treatment cure to make sure like you were positive for gonorrhea, we gave you antibiotics. We want another culture that says, yep, you're good, the antibiotics worked. So my gonorrhea and chlamydia cultures were negative on my first visit. They were negative at 36 weeks. So why do we still give the baby a rapamycin ointment to the eyes if the cultures are negative? Well, the issue is sometimes maybe you've had sexual activity after you had the culture done at 36 weeks, and you may have had exposure to gonorrhea or chlamydia. The other thing is maybe your culture was not accurate. Maybe they didn't get a good swab there. So again, the risk to the baby from the erythromycin ointment is very, very small. So better safe than sorry because gonorrhea and chlamydia can affect the baby's vision. But there are some patients who refuse for their baby to have erythromycin ointment. Okay. The end of pregnancy, things can happen, they just turn on a dime. You are fine on Tuesday and on Thursday, you're in the hospital, your blood pressure's sky high, you're swollen like a pincushion. It just happens overnight. It's amazing. So we really need to watch the patient very carefully. With patients high risk, we actually can see the patient more than once a week. So you may have patients who are coming in Monday, Wednesday, Friday, Tuesday, Thursday. They're getting non-stress tests, they're getting ultrasounds, they're getting, they're just really watching. You're like, come on, deliver the baby. Remember, we're trying to get to 39 weeks before we do any interventions, okay? We do not decide whether or not to induce the patient. The physician, the midwife is the person who decides that. We don't decide whether the patient's a C-section. The physician, the midwife, the nurse practitioner, those are the folks who decide that. So the patient needs to know when to go to the hospital. So you go to the hospital when your contractions have been about 5 minutes apart for about an hour, hour and a half or so, regular. And when I say contractions, they're not the smiley kind of contractions, like, ooh, I'm having a contraction. They're that kind of contractions. But you also want to be careful, you know, first-time moms, you don't know how labor's going to go. So the textbook says you're going to be in labor like 18 hours. Well, some moms, their first babies are only like 6 hours. Right? Maybe it's me, I don't know. But you don't want people staying home too long, because then they'll have the baby on the side of the interstate, or in the taxi cab, or in the back of dad's pickup truck, okay? So if the water breaks, if you're contracting, you're not feeling the baby move, that's when you need to go to the hospital. All right, how are you feeling so far about OB? First week of OB. Was it as horrifying as the stories led you to believe?